just obviously deal mostly with arthritis. So just by way of disclosure, I've never done a hip arthroscopy. I actually do almost no arthroscopy, a little bit of knee arthroscopy. But so I do deal mostly with joint problems, arthritis, and revision. So when you guys see a labral tear, you get excited, you're passionate about it, and when I see something like this, I get excited and passionate. So, under duress. But there's no doubt that I see a fair amount of patients with hip pain, with mild to minimal arthritis, and I always say that the goal is to keep those patients away from somebody like me and get them over to somebody that could hopefully preserve the joint and keep the progression from mild to severe. But there's no doubt hip arthroscopy has so many advantages over hip replacement. In contrast, it's an outpatient procedure, shorter rehab, and but the other, it also has a wide variety of indications, but it can also, and I think this is very important, doesn't hinder that next procedure, which could be arthroplasty or not arthroplasty, but some secondary procedure which can occur. Of the many indications for arthroscopy, labral tears, loose bodies, impingement, early AVN, infections. I haven't tried it with an infected joint, but there's certainly people that have done that. But I think what and mechanical symptoms, but I think what the caveat that's repeatedly said is basically without significant joint space narrowing, and I think that's something that we all kind of banter about and talk about and debate. So I think the question is, what is significant joint space narrowing? How much arthritis is too much? But I think you have to look at that in the context of the age of the patient and their desired activity level. So the goal of successful arthroscopy comes down to patient selection, assessing the overall condition of the joint, and then obtaining an accurate preoperative diagnosis. So I think it's interesting to me when people talk about the failed hip arthroscopy and how that's conversion to a total knee or a total hip. We don't really hear that in the knee population. So people, as early as 5-6 years ago, were still scoping our arthritis in an effort to clean it out, and I have a lot of knee patients come in, with clear bone-on-bone arthritis, having just had a knee arthroscopy. But we don't really see that in the hip world. So there's several studies that have come out talking about hip arthroscopy. I think it's universally agreed that there is a correlation between the presence and degree of arthritis, and that leads to a less optimal patient outcome, especially in the early setting of arthritis. So arthroscopy has certainly been shown to be helpful in AVN in the early stages, especially with the persistent pain and the mechanical symptoms. But it's a difficult population to treat, even in the arthroplasty population. I think they can often be poor candidates for hip preservation, especially in FICOT 3 and 4. Studies have shown 35% of patients can improve, but 40% go on to require hip arthroplasty within 8 months. So I think it's something that is, AVN is probably a difficult problem to solve. In young, active populations, especially the under 50 population, studies have shown that patients have avoided hip replacement for up to 1.5 years on average, but those patients had less than 2 millimeters of joint space. So those with more than 2 millimeters of joint space left saw an improvement in pain and function, and they had a very low conversion rate to a total hip, so less than 3%, which I think, given this population, I think is an excellent result. So Ben and Justin earlier talked about arthroscopy and PAO in the setting of DDH, and those patients are known to fare worse with arthroscopy, on average in one study, avoiding total hip for up to 10 months, but I think it's clear that these aren't normal hips. You have femoral head uncovering, you have the impingement, and that results in increased joint forces across the cartilage and labrum, and obviously the abnormal stresses in the joint. The treatment of chondral defects has also been looked at with arthroscopy. It's certainly successful in the setting of mild defects, but grade 2 or greater were less successful. Grade 3 or 4 saw an increased risk of conversion to a total hip, which, given this population, and isn't truly surprising. So like in the knee, radiographs and MRI, I think can underestimate the amount of arthritis as well as the chondral lesions that can be present. So I believe we need a better tool to understand the context of our osteoarthritis, and MR arthrography may be part of that. And as MR techniques improve, so will our understanding of these cartilage defects. Just want to go through a couple of cases very quickly. I had a patient come to see me, 59-year-old male, very active, history of right hip pain, basically activity-related groin pain, very athletic, exacerbated by activity, and I looked at his x-rays. I didn't really see a lot. I sent him for an MRI, which showed a labral tear, and I sent him for some therapy, referred him to Ben. Ben got some additional x-rays. You can see fairly severe anterior arthritis. He had an injection, didn't really get better. Ben's a lot smarter than me, avoided the hip scope and sent him back for hip replacement. Another patient is a young woman, 24 years old, history of right hip pain. She had very debilitating pain in the groin, former cheerleader, exacerbated by activity. She had had a previous open dislocation in St. Louis and then had 2 subsequent arthroscopies. Still did not improve. MRI showed no evidence of AVN. X-rays looked relatively normal. And so with some reluctance, I took her to the operating room to do a total hip, and on her sectioning her femoral head, we saw severe edema and sort of a bloody infiltration, but with relatively preserved cartilage. And then after the hip replacement, she actually felt better almost immediately and had a great recovery. So I think to summarize, we don't really know a lot about what can cause the persistent groin pain for some of these patients. I think our understanding of these MR techniques as they improve and as we learn about appropriate patient selection, I think we can pursue extremely low conversion rates to arthroplasty and keep hip preservation alive and well. So with that, I just want to continue on talking about hip replacements. So when I talk to patients about hip replacement, I tell them that life is about balance. So they have to give up something to get something. So the trade-off for pain relief and enhanced mobility, in my opinion, should be moderation of their activity levels. But unfortunately, we don't know about the life expectancy of both the patient as well as the implant. And neither of those can be fully predictable. So there's no doubt that hip replacement is one of the best interventions we have available for both pain relief and getting patients mobile. Lots of studies support hip replacement is one of the most effective tools to treat a variety of problems, normally hip arthritis, as it occurs through many etiologies. It's a very cost-effective tool for the treatment of degeneration of the joint. So I like to think of hip pain as a spectrum of problems which ultimately end up in arthritis and subsequently hip replacement. So I think the goal of the conference is try to prevent or at least delay this transition from a variety of etiologies. But once that diagnosis is made and the decision for arthroplasty is discussed and decided upon with the patient, I think it's important to have a discussion about their goals, and then compatible with that, fixation options and bearing surfaces. I think everybody who does arthroplasty, the goal is a long-lasting, durable fixation, and the enemy of that is wear. So there's lots of historical studies about total hip in young patients, and they haven't generally been very favorable. There's no doubt that polyethylene debris, which was once thought of as cement disease, can cause significant osteolysis, bone loss, and the subsequent loosening requiring revision surgery. As you can see on the patient's right hip, the clear signs of, she actually previously undergone a bone grafting with retention of her cuff, but you can see that there's significant osteolysis around her cup, and she didn't have the same luck on the other side. But fortunately, the newer designs that we're doing now, particularly with the highly porous surfaces, have allowed for excellent cementless fixation options and excellent results with fewer revisions, almost no revisions for loosening. So prior to the introduction of these newer polyethylene wear was the main limiting factor in the lifespan of many of these implants. So in this patient, young guy, 37 years old, he had a total hip done 7 years ago after for AVN. He had a dislocation, went on to develop AVN, had a total hip done. And you can see he has the classic signs, eccentricity of his femoral head and the acetabulum, and then the supra and retroacetabular osteolysis, especially along the ischium as well, which denotes wear of the posterior wall. And while he wasn't having a lot of pain, he was basically a couple millimeters away from catastrophic polywear, and so retention of a well-fixed cup and bone grafting, and then removal of the polyethylene debris generator, namely old poly and a liner, can be a reliable alternative for revision. So as we've seen with the push for arthroplasty in younger patients and younger, more active patients, I think fixation problems have largely been solved by the use of highly porous implants, particularly femoral and acetabular components. But however, the wear is still the enemy, and that has led to the development of alternative bearing surfaces, particularly the use of hard on hard bearing surfaces in younger patients. So bearing surfaces come in many different varieties: metal on metal, metal on ceramic, ceramic on ceramic, especially the delta on delta, and then highly cross-linked polys, which is both metal or ceramic on highly cross-linked poly. So wear studies have demonstrated a significant reduction in the wear rates and therefore polyethylene debris formation in these bearing surface options, particularly the hard on hard. And that's shown almost minimal to negligible wear rates compared to the more traditional bearing surface options that we've used in the past. Metal on metal is not a new concept. It's been around for decades. Some of the earliest hip arthroplasty options were metal on metal designs, which were largely abandoned many decades ago for reasons including debris formation, loosening, and also poor designs. But the newer implants with new metallurgy, new manufacturing techniques, and better tolerances led to a resurgence in the field of metal on metal, and those performed well in some studies, not all. But it's certainly, we know, almost minimal wear. And I didn't do a lot of metal on metal, but I certainly did some. You have a 40-year-old man comes in that needs a hip, and there's really not a lot of great options for that patient. But with these newer designs, certainly the larger heads was a response to a real problem, dislocation. And that used to be the bane of our existence in the arthroplasty world, but that was largely solved with the formation of large metal on metal heads and those articulations. In fact, I've known surgeons anecdotally that were using metal on metal in the hip fracture population because of that problem, because of the low risk of dislocation in that with metal on metal heads. But with some of these newer designs came new problems, and I think the debate about systemic metal ion release is still an ongoing problem. Surface corrosion of large femoral heads on the trunnion, as well as metal liners within the acetabular component, has led to a higher failure rate in many of the recalls that we've seen. But one of the things that we don't know about is what the prolonged toxicity of metal ions. Clearly, metal exposure hasn't been good for him. But I think we don't know about the possible, the many side effects that could happen with metal on metal. And I counsel those patients who I discuss metal on metal. I discuss with them all the different options. So we know that there's evidence to support altered T cell, B cell, and macrophage response to the metal ions, but there's no link at present between cancer and metal ion exposure. But what I think is also important is, and this is something that people don't like to talk about, but it's how to do an appropriate acetabular orientation for a metal-on-metal hip. And as the studies that came out of the Massachusetts General were probably not as good as we think we are in terms of placement of acetabular liners and cups. So it's significant that it's clear that doing a total hip with metal on metal, the cup is probably the most sensitive component for wear, and so higher inclination angles may lead to higher wear rates and higher metal ion levels. So the biggest problem that we've seen thus far with metal on metal is fortunately a very rare phenomenon, but alval, pseudotumor, or local tissue reaction response. It's got many names, but that can cause significant pain and soft tissue destruction, particularly the abductors. And as we've seen, that can be a very difficult problem to fix. Fortunately, it is rare though, accounting for only 3.5% of all the revisions done at the Mayo Clinic over a 3-year period. We saw that there was a majority of these patients were women. Not as many were resurfacing implants, but they did comprise many different companies with a variety and broad spectrum of implants, some of which have been recalled. So I think there's still a role for metal on metal, although it's probably somewhat diminished than its exuberance 5 or 6 years ago. But I think it's still an appropriate indication in resurfacing patients who are still out there seeking that procedure. But I think with appropriate counseling, optimum cup placement, active male patients without a risk of renal disease could be considered candidates for metal on metal hip replacements. Ceramics have improved significantly and are now probably the most favored implant surface option, especially the excellent biocompatibility of ceramic in contrast to metal on metal. It has excellent wear characteristics and extremely low wear rates, but no bearing surface is perfect. The risk of fracture, even with the new Delta ceramics, have significantly diminished compared to the aluminum ceramic, but there's still a risk of impingement and squeaking, and larger ceramic femoral heads also use a metal taper junction, which can cause corrosion on the trunnion. But with these improved manufacturing techniques and smaller grain size, the burst strength is excellent, and I think it would be rare to see catastrophic failure in these implants. So highly crossing polyethylene, certainly tried and true, been around many decades, and it works well without the potential downside of some of the hard bearing surface options. We have excellent midterm data on some of the polys that have been out for 10 years, but I think everybody has heard about new and improved techniques in polyethylene. I think what we need to know is, the long-term wear in vivo. We have excellent wear data coming out of knee simulators and hip simulators, but how these translate in vivo is still something we're learning about. So there's no doubt that the improved polyethylene components have come about because of our better understanding of wear mechanisms, better techniques to test them, and but more studies are being done under aggressive testing environments. Improving the cross-linking of the polyethylene with these techniques have improved the wear resistance, but it comes at a cost in terms of lower strength and resistance to crack propagation. However, I think the diminution of these mechanical properties is small, and the downside is limited by the improved wear characteristics of these surfaces. So to summarize, I think we can say reliably that improved bearing surfaces have provided outstanding results for patients, coupled with excellent fixation options. I believe that hip replacement can be performed safely and reliably with young, active patients and can provide long-lasting, durable results. So what do we offer now to young patients requiring hip replacement? I think it's best summarized by age. In the very young, under 25, I would consider ceramic on ceramic, especially the newer Delta ceramic bearing options. I personally have pushed my age up at where I would consider ceramic on highly cross-linked polyethylene up to 70, 75, even older, depending on their physiological age. But I think it's still reasonable to use metal on highly cross-linked polyethylene, which could give outstanding wear for the lifetime of patients who are a little bit on the older side. So with these new bearing surface options, I think activity levels are what keep arthroplasty surgeons up at night. I've had patients admit to running. I had a firefighter tell me that he passed his physical fitness test and he was running, I think he said he had to run 3 miles in under 30 minutes, which I think on a hip is probably pretty good. But in general, I don't advise patients to run. I think there's a wide spectrum of what arthroplasty surgeons recommend for their patients, but clearly high contact sports with the pivoting, twisting type activities like basketball, baseball, softball, snowboarding are probably not something we recommend. But I think it's, in general, it's going to be a learning curve as we learn about these implants and what they can tolerate and what patients can achieve. I think we can let loose some of the restrictions that we've put on patients. So I generally tell patients that it's a balance. The goal of the surgery is to relieve pain, and they have to accept some limitations for pain relief. Thank you very much.